We also recognize the Assistant Director of the PanAmerican Health Organization, Dr. Jarbas Bubusa, Dr. Merle Lewis, Chief of Staff of the PanAmerican Health Organization. We have with us as well Dr. James Fitzgerald, Director of the Health Systems and Services with the PanAmerican Health Organization. We also recognize all other PAHO delegates who are with us this afternoon. Also with us, we recognize the staff of the Ministry of Health, Wellness, and New Health Investment, including the district medical officers, nurses, health educators, and all other staff. Good afternoon and welcome to this symposium. Let me apologize on behalf of our permanent secretary, Mrs. Letitia Lestrade-Wyke, who is unable to be with us this afternoon due to unforeseen circumstances. So we indulge your patience, you indulge your cooperation and your understanding as she sends her best regards this afternoon. The symposium is on the primary health care and non-communicable diseases and the situation as it relates to the host country, Dominica. So first off, this afternoon, we welcome to give the opening remarks, Dr. Irvin McIntyre, the Minister of Health, Wellness, and New Health Investment.
Thank you, Ms. Harry. Let me first recognize our director, Dr. Carissa Etienne, our assistant director, Dr. Barbosa, all the different directors and heads of PAHO here this afternoon, and obviously you, the esteemed people related to primary health care. Let me welcome everyone here this afternoon. It's my pleasure to welcome you here at this symposium on primary health care and non-communicable diseases. It's a very timely intervention, I must confess, because as the Prime Minister said repeatedly, we think that non-communicable diseases creates one of our major issues and one of our major threats as regards to our socioeconomic development as a country. But besides that, obviously, we know that primary healthcare forms the basis in our transformation and building our healthcare system. Obviously, just like any house, you build from the foundation upwards. So we are very much aware that for us to transform and to build a better healthcare system, it has to start from the primary healthcare level. And so that's why it's very fitting and very opportune that we're here to have this symposium on primary healthcare. And well, we're also focusing on the non-communicable diseases. And we have to recognize that it has to be a multi-sectoral approach. And as a government, we have recognized this fact. So it would seem meaningless if we were to be discussing non-communicable diseases and not recognize that we must have the Ministry of Education on board with us, because that's where our school nutrition program starts off. And that's where we can put all the little mitigating factors into place as regards to nutrition. We also have the Ministry of Sports must be on board in terms of physical activity. Ministry of Agriculture must be on board in terms of growing what we eat and eating healthy foods and our food chain. And also in terms of housing, the housing ministry, because obviously these are the social determinants of health. So it's actually a multi-sectoral approach, whether it's agriculture, housing, whether it's sports, education, everyone must be involved. That's how primary healthcare is going to be successful, and that is how we're going to fight these chronic non-communicable diseases. And we're fully much aware of that as a government, but not only just the multi-sectoral part of the ministries and the government, but also we recognize that the community must be part of it. Over the COVID pandemic, we saw little lapses and little gaps in the sense that even our vaccine resistance, to a certain extent, it could have been attributed to the fact that maybe there was a slight disconnect between some of us healthcare workers and the community. Not to blame the healthcare workers, it's just that the community didn't come on board with us for whatever reason it is sometimes. So in all of this, we have to also engage our community, and so that this can be very, the intervention that we're going to put in place can be worthwhile and it can target the exact people that we want to target. Also, there has to be a certain level of passion among us, in the sense that we have to own what we're going to do. We have to own the system and there must be a passion, and we have to see our mission. As healthcare workers, that's our intention. We're going to target the non-communicable diseases, and so if we own it, if we have the passion for it, we take it as a mission, I think we'll be much more successful. But I've worked with many of you, and I've seen the passion, and I know your enthusiasm, so I'm not panicking about that. I'm very optimistic, and I think we can do it. So you have my full support. You have the full support of the government and all the other different sectors within the government, not only the Ministry of Health, but all the other departments, all the other ministries. And you have the commitment of the government. The Prime Minister has spoken repeatedly about this. And I think this is such an opportune time that we have all the experts from PAHO here with us. And I would consider us very, very fortunate, because you could try to imagine having to bring down these experts at separate times individually. But lucky for us, we are the Vaccination Week of the Americas, and we have our regional heads here, and all the directors are here. So we have all the intelligence and all the support that we can possibly have. Now, in terms of the primary health care, obviously the information aspect is very important. And we also have the experts regarding the information, health information. And as a matter of fact, we've been having meetings. They had a meeting this morning with the digital economy. They're having another meeting this afternoon with the hospital authority, because we recognize that for the health system to move smoothly, there must be this collaboration and there must be this interconnection between the primary and the secondary health care. And that is where the information aspect comes in. So it's a very comprehensive approach. I think we're in a good position. I'm really optimistic, just as much as you are. So let's just sit back, let's just bounce off our ideas, and let's just see the new vision for healthcare in Dominica. Thank you so very much.
Our thanks to Dr. McIntyre, the Minister for Health, Wellness and New Health Investment. Our next presenter this afternoon has expressed on several occasions how near and dear primary health care is to her heart. So I welcome to the podium the Director of the PanAmerican Health Organization, Dr. Carissa Etienne, to present Primary Health Care, Fundamental to Transformation and Resilient Health Systems.
Thank you so much, and good afternoon. And I'm so happy and pleased to see so many of you here as we begin a journey to transform the health systems in Dominica in a comprehensive manner, to ensure that every man, woman, and child has the possibility of living a healthy and productive life, and that no one will be left behind because of where they live, who they are, whether they have money or not, but that all, in the whole spirit of equity and rights, that all will enjoy health and well-being. And I see that as one of the major objectives of any healthcare worker. And that's why we've signed up to it. And so this afternoon, I intend briefly, because I can go on for the whole afternoon and you wouldn't like that, and there are others to speak and share wisdom with you. I will give you a short historical journey through primary healthcare, not only in Dominica, but primary healthcare in the world. Show very quickly how that was expressed in Dominica and the relevance for the NCD epidemic that we are experiencing, and how we need to transform, to tweak the primary healthcare hospital so we can ensure better promotion, prevention, treatment for persons with NCDs. So, you know, as we are hopefully exiting out of COVID-19, more and more the world is giving attention to we need resilient health systems. So that's what they first started to see. We need resilient health systems that can best be able to address and respond to another pandemic. And then increasingly they began to say, we need the essential public health functions to do that. And more importantly, they say, the transformation of health systems and services must be based on the primary healthcare approach. We are coming full center. back to where we need to be. And that's happened over and over again. So in this context, we were invited by the government to look at the health systems in terms of the transformation of health systems, and we are working with the hospital authority. We are meeting with you, and this will not be the first time that you're seeing us. It will be an opportunity for us to work together. This is not PAHO's country, this is your country. We can accompany you on the process. We can help you with the expertise and some funding, but it is together that we will work to transform the health systems in Dominica. So once again, we will be the pearl in terms of the model of a transformed health system that can respond to the common conditions of its time, that can ensure readiness to face pandemics and crises, but can deliver health care on a daily basis to its population. So I want to begin by saying that it is a disaster that got us into the primary health care agenda. It is Hurricane David, and I often say Hurricane David was a blessing in disguise. But after Hurricane David, a number of us were looking to rebuild the hospital and recover the hospital services, but Alma Ata was 1978. And so all of the help that we were getting, and PAHO was at the forefront of that at that time, was saying, why don't you work on your primary health care services? And so this is how our eyes were turned to primary health care. And I want to pay homage to the team, the core team. And the core team consisted of Desmond McIntyre. Dr. Desmond McIntyre, he was a surgeon, but turned a health administrator. He was the health services coordinator. And he actually came and offered his services after Hurricane David, because we needed leadership at the time. Jennifer Astafan, who was the health planner at the time, Jean Jacob, who was the principal nursing officer, John Fabian, who was the chief environmental health officer, and myself. We were the five. And we were supported by a wider team of, we used to call it the Technical Coordination Committee. And there we had hospital medical director, hospital administrator, the lab director, the chief pharmacist, also health education, health promotion. Why am I telling you all this? It is not a single person that can transform. It is a team approach at all levels that can bring about transformation. And so this is one of the messages that I want to leave with you. Now, some of you who have been students of primary health care and public health, you will remember the definition of primary health care. Primary health care is essential health care based, but listen to the words, please, based on practical, scientifically sound, and socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation and at a cost that the community and country can afford at every stage of their development, in the spirit of self-reliance and self-determination. There are many, many words in there. And so we saw that the basic principles were accessibility, that we needed, if the primary healthcare approach was going to work, we needed to address barriers. There were geographic barriers, cultural barriers, financial barriers, but barriers of all types had to be removed for greater accessibility. And the emphasis on community participation. And I need to tell you, Dominica probably had the most village health committees and district health committees, and they were not just in name. They were active, very, very active within their communities. And the emphasis on intersectoral coordination. If you ask me, we never got that one right. That while at the district and community level, the different branches, like the headmaster or mistress, fire department, and so they were engaged in the whole process. But at a government level higher up in cabinet, there was not sufficient intersectoral coordination. Now, if we're talking about NCDs, this is absolutely necessary, and it is something that we need to address. The only part of intersectoral coordination that was also very right was civil society engagement. So most of those were community-based organizations, not necessarily huge, the NGOs, etc., but the community-based organization. And importantly, appropriate technology. And we will see how appropriate technology is extremely important if we are to prevent and to deal with NCDs. And at the time, the most effective appropriate technology at the time was oral rehydration salts, ORS. Because at that time, we were dealing with diarrheal diseases that was killing children. And the most important technology was to rehydrate those children with oral rehydration salts. So it wasn't anything sophisticated. It was, no, there were 8 components that were listed. One of them being health education. And I can tell you, the health education that went on in Dominica was rooted at the village and the district level. And the village health committees were very much engaged in the actual turning out of the health education, supported by a health education unit and the person. We found that it was more beneficial, it was more impactful if we transmitted the information to the health district people and the community persons, and they organized the education for the wider community, because they spoke the same language in terms of the understanding of the social situation and what they had to deal with. And health education was very strong. Also, a proper nutrition was an important component. At the time, most of the world was continuing to deal with undernutrition. Now, of course, we have the opposite. We have too much obesity. But that was one of the key components of primary health care. Clean water and sanitation. I don't know if you probably don't remember those days, but most of our houses and homes and persons did not have access to sanitation. There was not generally sanitation in the homes. And there was open dumping. Open dumping was practiced throughout. There was no organized collection of garbage. It was open dumping. In fact, the first collection service that was organized by the health district of St. Joseph. And they organized a garbage pickup, first time in Dominica. Maternal and child health, and that was the core of our primary health care programs at the time, maternal and child health programs, because we were still seeing many maternal deaths, we were seeing premature, we were seeing child cares, infant mortality was still high, but child mortality also was still high, and so there were programs addressing maternal and child health, and also immunization, very importantly, being part of the 8 components, and control of common diseases and conditions. If you listen to the discourse at that time on primary health care had to guarantee service for common conditions. Now you tell me what is the most common condition that we have in Dominica now. We will go there. Accessible treatment and drug provision. So all of those are the 8 very important components of primary health care. And that was already from 1978, you see, from the Alma Ata Declaration. And at the time, those of you who were students, no, you weren't there, you're too young for that. We had to learn the 4 A's. The 4 A's of primary health care was accessibility, availability, affordability, acceptability, and appropriateness. So you can mull on those 4's because each of them is. So Also, they advocated for well-defined geographic areas or catchments, and that care should be delivered by a health team with a well-defined management group. So a team approach at all levels was really given priority as the way to deal with, to work with your health staff in a coordinated manner. So some of the, how was that expressed in Dominica? So we defined the health districts. We defined 7 health districts. Before that, the medical doctors used to travel from Roseau, except for Portsmouth and Marigot, that had resident doctors. The doctors traveled from Roseau to all of the different areas to provide care. That's how care was provided in Dominica. When we started the transformation, that's how the 7 health districts came into being. And we decided that in each health district, there will be a type 3 center at which your managerial staff and your more highly qualified staff, quote unquote, would be located. And we would have type 1 centers, which would be smaller populations and would be manned by a primary care nurse. We didn't have a primary care nurse before that. So we trained primary care nurses so they would be able to deliver general care and maternal and child health. So that's how primary care nurses came into being. What also came into being was the family nurse practitioner. We didn't have FNPs before that, and we began training FNPs. And so there was a district medical officer assigned to every district, and that district medical officer had to live in his district. There was a primary care nurse to every type 1 center, and at the type 3 center, you had the community health nurse, those who were public health nurses at the time. You had your, I said the medical doctor, the family nurse practitioner. We had a dental hygienist at the time as well. You had your environmental health officer for the district and your pharmacist for the district. So all of these people at the central type 3 would go out to provide service also to the population. So we expanded the health team. We established a primary healthcare department. There was no primary healthcare department before that. We established the primary healthcare department, and we strengthened the primary healthcare department with trained individuals. So increasingly, we had people trained with masters of public health, a health educator trained, and various staff that would be able to manage the primary healthcare service. I talked about the village and district health committees, and they were very powerful. Once a minister tried to, because he couldn't come to the district committee meeting, he tried to cancel the meeting by sending a message on the air. And the people say, who is the minister to stop our meeting? So they continued and have their meeting. We had to talk to the minister to say, it's not our meeting, it's their meeting that they have invited us to. So you can see the power that these people had. But remember that all of this was taking place in a situation where we had devastation by a hurricane, where facilities had been destroyed, where the distance, the distance between here and Trafalgar looks very little now. The distance between here and Soufriere or here and Point Michel. But before that, it was quite a distance because we had no transportation readily available from one district to the next. I'm telling you that because you need to see how things have changed and maybe how we need to make adjustments. We had a health information system. A health information system was designed that supported patient care, and that's how the exercise books came into being, because that was the patient health record, and Dominicans took care of the exercise book. And that exercise book went, wherever they went for service, that exercise book went with them. So we had the patient health record, We had the information systems accompanied every care that was given. So in support of patient care, but also in support of the monitoring and management, because type 1 centers had to send a full report to type 3 centers on a weekly basis. And the type 3 centers had to send monitoring reports to the primary healthcare department every 2 weeks, until after some years they began to complain, and so we said, okay, once a month. So at that time, we were able to sit in Roseau and know that the nurse in Trafalgar or Petit Soufriere was not doing sufficient, not seeing sufficient patients in the child clinic. We're not seeing sufficient pregnant women, because we would have done a planning exercise where we use the population of that district and that catchment area and applied a formula, so we know how many pregnant women should be in that community. We knew how many children had to be vaccinated. So when they sent their reports, we were able to see whether they were actually delivering the quantum of care that they needed to deliver. And of course, we had some quality indicators as well. All of that was not supported by a computer. All of this was manual, but it was done. We had a home visiting program, and our nurses used to go to visit every house. And we also monitored this. Not only did we do home visiting, but every nurse knew every house in her community. The houses were numbered to help us with the information system. So we did a mapping and house numbering. This mapping is still being done. It's still being done. It's not, I think a lot of us in Dominica think, oh, those things are old and they are past. Yes, they're using technology now to make the work easier. But the environmental health officers had to draw the maps, and you could see them on the wall, and they would put the houses, and you would know which is a shop, you would know which is a school, and all of that was done manually. And then if you went and visited, you would see the pins. So where a red pin was somebody with TB, a green pin was something else. So you could actually just look at the map and know what was happening. But we had those recorded too. So we knew how many TB patients were in this community, but we also were able to say how often you were seeing them and how well they were doing, who was going to hospital, etc. And we had the health educator that was added. Importantly, disaster preparedness, because prior to Hurricane David, disaster preparedness was really not developed at all. And it is after this that we developed our whole disaster preparedness and mitigation, etc. program. And of course, to facilitate all of that, we had meetings, seminars, workshops, until Ministry of Health was known as the Ministry of Seminars and Workshops. Now remember, the way you invited people was on the radio. There were no telephones, because all telephone connections were discontinued. So we used to send messages on the radio to invite the nurses and different people to the meetings, and they all came, because people were really enthusiastic about some of the changes that were happening. Of course, we started all of that in the La Plaine Health District, and then moved out to other districts. So you asked me what has changed. And I need to tell you that much of the principles and the concepts are still the same, So what you have is not old-fashioned, and what you have is not irrelevant. And I want you to appreciate that. Of course, we can find new ways of making it easier. We can use technology to get us there faster, but not too much has changed. But some has changed. Over the years, we've seen a greater emphasis on health as a human right, and that is globally, and much so for the region of the Americas. And that ensures, if we say that health is a human right, then government has a responsibility to provide health, comprehensive health for all of its population. There's a growing and increased emphasis on equity. The equity, and in our region, we say there's great inequity, but this is one. I think importantly came the health promotion strategy and the sequential health promotion symposiums, or the World Health Organization symposiums on health promotion strategy. And some of the things that those emphasized were equity, social and environmental determinants of health. So you hear people talking more about the social determinants of health. An emphasis on multi-sectoral approaches, which by that time had lost the emphasis that we needed. Social participation, so instead of community participation, you hear them talking about social participation. And all of government approaches and all of society engagement and health for cities, and importantly, the need to create the enabling environments so people can live healthy lives. So yes, you must tell me to cut down on sugar, and then all of us are trying hard to cut down on sugar, but the best way to reduce sugar intake is by putting heavy taxation on sugar. So if you put taxation, increase that sufficiently on sugar, then people will stop buying and eating so much sugar and sweetened beverages. If you want people to stop tobacco, you increase the taxes so much that they cannot afford to buy the amount of cigarettes that they used to buy. So that is how you create some of the environments that people can live healthy lives. And we also saw this emphasis on persons in conditions of vulnerability. So the emphasis, not that I provide for everybody, yes I should, but I must also target those people who are being left behind and those people who lived in vulnerable conditions like women and children, indigenous populations, etc. Early on in primary healthcare movement, the essential medical lists were important. And I don't know if it still happens now, but Mr. McIntyre had given me an assignment to go into central medical stores and to clean up central medical stores. Because so you see me in my genes, and so I'm a medical doctor, but that's what I was doing with the pharmacist. Because after hurricane, people send you all sort of stuff. But we had to clear that, and we had to develop an essential medicines list. And that essential medicine list was already developed by WHO. So we had to adopt it and make it relevant to the local situation. And that helped to guide our formularies, our drug formularies for national, hospital, and etc. I think important, the whole reiteration of healthcare as being comprehensive. So it's not just treatment with medicines, etc., but it's promotion, it's prevention, it's care, curative care, and then rehabilitation was added, and I'm missing one, palliative care was added. So the whole comprehensive health care. And then the essential public health functions. Some of them repeating some of what was under health promotion and what was under the whole primary health care components, but importantly stressing surveillance. I think that's the most important, surveillance and research. And surveillance is even so important now, as we must make ready for a new crisis, a new pandemic. We must ensure that we can follow up disease programs, both chronic, non-communicable, and infectious diseases. Also, you saw a movement into expanding technology. It was no longer enough that a patient comes to your health center and you have a blood pressure machine and a scale and what else? And then after that, we were testing urine. There wasn't even any blood sugar testing at the time. So little by little, that began to expand. And the important thing is that your primary health care or first level of care programs must be able to solve people's problems. What is the point of me coming to you and all you can do is check my blood pressure and my urine and take my weight, and then you say, okay, I will send you to hospital? No, I'm going to bypass you, and I'm going to go straight to hospital. And once a person steps into hospital, the cost rises dramatically. So we have to make sure that our primary care systems can solve problems. And so we have to expand the health technology. We have to bring in digital transformation, telehealth, telemedicine approaches. We have to increase the diagnostic and treatment capability at the first level of care. It also ensures, and at that time, people started to look at the role of the Ministry of Health. Because at first, the Ministry of Health delivered services, but then it gradually began to look at what is the governance and regulatory and stewardship role of the Ministry of Health. And how must we therefore develop the Ministry of Health so it can provide those services, these oversight services for all of the primary health care and secondary care. I think I'm living on one very important thing. At one time, the primary health care worked, the hospital worked, there was no coordination across. And that is essential. And we've moved into what is called integrated networks of care, where it can't be the first level of care working on its own and the secondary care or a hospital working on its own. We have to have a common planning, a common approach, a sharing of expert services or specialist services, an ability to refer and counter-refer. So this coordination is more and more important, and we see it being expressed across the region, where people are focusing on integrated networks of care as the best way to deliver effective care as well. So let me tell you, if I asked you what is the most common condition or disease that you must work with now, what would you tell me? Or you're not listening to me. It has to be the chronic non-communicable diseases. 80% of your mortality is from NCDs. And many people are dying prematurely. You hear young people with strokes, young people with heart disease, young people in heart failure, diabetics, amputations, dialysis, all of those things. In the early 80s and 90s, you know what were the common diseases and conditions? Diarrheal diseases, typhoid fever, we had other communicable diseases, vaccine-preventable diseases. We were still seeing measles for some time and having to deal with it. We had a big helminthiasis problem, worms, because we didn't have any toilets. So it was open defecation. So we saw lots of worms. There was undernutrition, and there was maternal and child health issues. So the structure of primary health care, the staffing and the program content was geared towards addressing these issues. And in a way, we are still in that mode. And using the model and mode that we have now, it is very difficult to address NCDs. So you tell me, we were very successful in the past, and it impacted overall economic growth and development, and as the country developed, it also assisted the primary healthcare programs. But really, we still need some of the principles and the approaches for the first level of care. But we must apply that now to NCDs. You see, when we were doing, we must still use promotion, prevention, education, management, community and social participation. We must still look at the health workforce profiles. And in the same way that when we were focusing on maternal and child health, we had a maternal and child health coordinator. We had community health nurses, or what we used to call public health nurses at the time. Their program was mainly MCH, maternal and child health. Our nurses, the majority of the program was on maternal and child health. But things are changing. And so we need to begin to look at our health workforce profiles and the distribution and focus of our health workforce. And the coordination with the hospital is even more important now more than ever. And we must have health information, and we must expand appropriate technology. It's not enough that we have nice buildings, etc. We have to have the technology that makes it easier to solve problems, else people will bypass our first level of care and it will become more expensive. So really, I think that we are at a time where we need adjustment. And I would dare say some radical new approaches at the first level of care and the hospital to turn the tide on this major epidemic of our time, which are the NCDs. So I really think that too many lives have been lost and too many years have been lost. And so we need to work in an urgent manner to turn the tide. I'm sure that when you hear our panelists, you will hear much more and you will see the NCDs and what we need to do in the context of a primary healthcare approach. Thank you. Maybe I've been too long, but thank you very much.
Our thanks to Dr. Carissa Etienne, Director of the Pan-American Health Organization. I know that both you and our Permanent Secretary were adamant that this take place while you were in country, so we appreciate that your busy schedule did not deter you. So thank you so much for that. Next up, it's only fitting that on the next topic, we have the Director of Primary Healthcare Services, Dr. Laura Esprit, with us, and she'll present on the context of NCDs and primary healthcare in Dominica. Dr. Esprit.
The Honorable Minister for Health, Dr. Irvin McIntyre. Can I remove this, please? Dr. Etienne, our PAHO Director, the Assistant Director, Dr. Barbosa, other PAHO Directors in their respective fields, the Ministry of Health co-managers, primary healthcare teams, our distinguished guests, the media, good afternoon and welcome. This afternoon I will attempt to address, beautiful, thank you so much, the context of NCDs and primary healthcare in Dominica. Our objectives are quite simple. Next slide, please. And as you can see, they're related to the burden of disease of NCDs in Dominica, more of the specifics, a little bit about primary healthcare dynamics, of course, some of the activities that we do have, successes and challenges, and recommendations moving forward. But as you can see, the overarching question is really, is it an opportune time to transform primary healthcare services? This slide, why is it there? Let's start on the premise that we have been in a pandemic for over 2 years, and that has significantly impacted and tested health systems of both developing and developed states on various levels. In Dominica, as we can see from the dashboard, approximately 12,000 persons were confirmed with the COVID virus. However, 63 persons succumbed to their death because of COVID. Next slide. Of these 63 persons, 81% suffered from chronic conditions, whilst a mere 19% did not. Of the 81%, though, those with chronic conditions, 51% were males and 49% were females, as you could see. Despite the fact, though, that COVID has had our attention for such a long time, 2 years, a long time, chronic conditions has been present with us for decades and has claimed the lives of thousands. But let's review the evidence. Next slide, please. Here you will see the top 10 causes of total number of deaths specific to 2020, all ages combined. And it is noticeable that NCDs account for approximately 80% of deaths in Dominica, as mentioned by Dr. Etienne. And that has been our primary culprit as it relates to mortality among Dominicans. And this has been a continuous trend, though, over the years, and certainly exponentially greater than the 63 lives lost from COVID. Let's now review some of our graphs, please. Thank you. Okay. So we have here data collected from 2011 to 2021. Here we see that the majority of patients with hypertension seen at primary healthcare clinics were between the ages of 45 to 65 plus years old. You could see the peaks, right? And it is quite concerning because that's the age group that tends to be, well, part of the age group, and it's in their reproductive, or productive years. And for this period, we see that females, the female visits dominated those of males. Although there is a confounding factor, though, that in Dominica, women tend to visit the clinics or access care more than men. Let's look at the next slide, please. It's specific to diabetes now. The data collected was for the same period, okay? And here we see that the majority of patients with diabetes seen at our clinics were also between the ages of 45 to 65 plus years old. Again, there is a similar trend for having more female visits than men. Next slide. Total cancer deaths, and we're looking here specific to prostate and breast cancer. So for the 10-year period of review, the mortality for prostate cancer was highest in 2020. I'm sure you'll find that very interesting. And this actually corresponds to the peak of the pandemic in Dominica. Similarly, the highest peak for breast cancer was in 2016 and also in 2020. Next slide, incidence of hypertension and diabetes per health district. So districts take note, please. For the period 2016 to 2020, the top 3 districts with the highest incidence rate of hypertension are as follows. Now, bear in mind, we have absolute numbers, but we also have the rate. All right, so in terms of rate, it would be Grand Bay, Casabruce, Portsmouth, and then La Plaine in that order. And for diabetes, it would be Portsmouth, Grand Bay, La Plaine, and Casabruce. Now let's take a look at what is being done in primary healthcare, again with the context of NCDs. But you could stay here, that's fine. What can we deduce thus far? It's very simple, but very striking. NCD population is actually a high-risk group for COVID-19 virus, there's no doubt. For many years, NCDs has been a serious burden of disease on the island, and it affects those among our productive population. And maybe a third inference would be that the strategy used to combat NCDs, it definitely needs changing in order to provide improved outcomes. Now I'll take you on a brief, well, Dr. Aide actually take you on a brief history already. So you saw what happened in 1978. But we had the catastrophic hurricane, we had David, and then of course Maria in 2017, and then the pandemic came. But now we believe that we're at a new juncture of actually discussing and implementing transformation of health systems, but importantly, by strengthening primary healthcare services. Administration, just for those who may not be clear, administratively, primary healthcare is divided into 2 regions. So we have Region 1 and Region 2 is almost as if Dominica is broken or split into 2. And it comprises of 7 health districts and over 50 catchment areas. And the district teams would actually serve a population of approximately 70,000 in almost 27,000 households. The services offered will be our next slide, right? So a wide range of services are offered to the public. While those I have listed may be directly related to chronic diseases, we have others that are offered in collaboration with other stakeholders. And the top right icon sums it up well. The services that we do provide, it's actually from the cradle to the grave. Infrastructure. With regards to infrastructure, primary healthcare facilities are as follows. We have 6 functional primary healthcare services. We had 7 minus Roseau equals 6. 42 type 1 facilities, 12 new modern health and wellness facilities with 3 pending, including Roseau, of course, and of course 5 PAHO smarted facilities. And of course, I try to use the different icons to sort of guide you as it relates to structure. Side by side, what you have here is a picture of a PAHO smarted facility, and that is in the district of La Plaine where it all started. And it's alongside a modern health and wellness facility that is actually located in the community of Maho. Next slide, okay. So this is an organogram, okay, and if you will, pay attention to some of our numbers here. If you notice, the Director of Primary Healthcare Services, along with 10 other managers, we all have staff who work together at the district level. And the staff complement is approximately 215 from my quick count lastly this morning. However, the director has the direct or sole supervision over the district medical officers, which numbers 22. Next, right, thank you. So this is just to give you an idea what the district, bear in mind we have 7 health districts, what the components would look like of the district admin team, okay? Next slide. Here we could see we have a total allocation for the Ministry of Health from the funds from the 2021-2022 national budget, and that's approximately 22%. However, primary healthcare receives approximately 7.29% of the ministry's allocation. And of course, the top 3 districts receiving the largest chunks of the budget would be Roseau, Portsmouth, and Marigot. And incidentally, those coincide with the largest district on island as per population. And of course, district administrative teams, they tend to manage their own budgets. Next slide. These are just some of the NCD-related policies that we've been able to accomplish, of course, in collaboration with various collaborators, but principally that of Health Promotion Unit. Next slide. So this slide is kind of busy, yes, and due to time constraints, I had to put it in a table form. But here you'd actually see some of the specific NCD-related activities that are done as it relates to prevention and awareness, screening, treatment, management and control, and of course, referral. Okay, and here I listed specific programs, the stakeholders, the mediums that we use, or some of the locations, and the persons responsible. Next slide. All right, so what are some of our successes? We have quite a few. Of course, the policies here are included. We have a very successful diabetic retinopathy screening and treatment program. The book that Dr. Aide mentioned, yes, it has its limitations, but it has certainly been a success for us. Our facilities, and of course, you should see here PAHO technical support. I mean, we cannot not mention that. And I highlighted here in red. This is something that we piloted, a structured patient appointment system during the COVID-19 response. And the reason why we did it was to avoid persons from intermingling. How could the ministry say that we ought to do social distancing and all of those beautiful things, yet at the facility, everybody's chalk and cheese? So that appointment system actually proved it worked very well, and the patients actually enjoyed it because there were times allotted to give quality care to the patients without the hassle. Okay, here you'll see, I just took a picture for you to see what the book looks like. And the patients actually treasure, put that in caps, their medical books. Next slide. Here you could see our campaigns, our vaccination campaign in various districts, primary healthcare services. Next slide. Vaccination campaign continues. Next slide. I want to pause here a little bit. This is something that we piloted. It was actually a comprehensive one-stop shop. And what it meant actually is that persons would actually come to access care but receive everything that they need as a one-stop, instead of coming to see doctor on a Monday, getting the medication on Tuesday, getting to see the FNP to check their feet on Wednesday. And that actually takes up a lot of time and minimizes, encourages the patient to be non-compliant. So the one-stop shop, we had quite a bit of our co-managers partner with us, mental health, health promotion, environmental health, and it was pretty successful. But this one was specific to the ministry, where we included all the ministries to participate, and it was a success. Next slide. And this one was specific to the community, where we actually piloted it at a community. I didn't mention dental and all the others I forgot. You know you were there. Next slide, please. Yes. I think they get a picture. Next slide. Right? And this one here is when we had a specialist clinic. So we had the urologists, ophthalmologists, and others join us at the district level, and that was quite a success as well. Next slide. And of course, you should know that one. This is a cohort of community health aides that were trained, obviously, sponsored by the PAHO. That was in 2019, if my memory serves me right, and 2021. And as we know, they are the foot soldiers of the primary healthcare teams, and certainly have proven to be so. Next slide. What are some of our challenges now that we've mentioned some of our successes? And these are just some. Of course, we have lack of standardization of our treatment. That is the reality of the situation. We have a lack of standardization. We have limitations in the access and availability of key personnel when needed. We have a lack of multidisciplinary team. Even the patient's attitude towards chronic diseases is an issue. So the patient has been treated for diabetes for 30 years, 20, 30 years. Do you suffer from diabetes? No, just a little sugar, just a little. There's no little. It's either you're diabetic or you're not. So this little thing we hear it quite often, of course. And of course, you know, with the herbs, the herbs tend to replace the medication that was prescribed, and its resulting complications. All right, and of course we have others that you could see on the screen. But the question now is, next slide, where are we heading? Where are we going with all of this? Okay. And moving forward, what's our goal? The quest really should be to have universal health coverage and to improve the access and availability of services. So as you could see here, I just listed a few. You heard when I mentioned about the comprehensive one-stop, our surveillance registry, even the reporting system, strengthening our referral system, patient-centered care. And you see here, use of measurable indicators or outcomes for the client. So rather than reporting, okay, we saw 40 patients for the day. What does that mean? How many were actually improved? Okay, next slide. Right, that's it, thank you. And of course, we continue here with some of the recommendations as to what can be done. So you notice here in the middle, we have surveys. So that should jog steps, right? The STEP survey and others are very, very critical. Standardization of treatment, and we know about the importance of the HATS initiative, health in all policies, intersectoral collaboration, and of course, improving the skill set at the district level. So moving forward in our quest to achieve, as I mentioned, universal health coverage, those are some of the considerations. But I am sure that you would agree, though, similarly to our approach to the pandemic, that we certainly need a more striking, cohesive, and aggressive approach to NCDs. In conclusion, certainly a renewed approach to primary health care is needed. It will help to address disparities with greater equity to all, increasing quality of care, service delivery, and of course decreasing morbidity and mortality, among other benefits. So is it timely to transform primary healthcare services? I'm hoping that you will say absolutely. And on this note, I really want to thank PAHO for the many ways they have contributed and supported primary healthcare over the years, and of course, in years to come. If I had to list the support that we've received from PAHO, we would be here until 7 p.m., thereabout. All right, so that's my conclusion. Just to take you to the next slide, that if you've not visited some of our sites, please try to. It's important for stress management. And lastly, these are my acknowledgements in terms of who supported me in this presentation. Thank you.
Our thanks to Dr. Esprit for that very comprehensive presentation. Thank you so much for that. We're going to do a little switcheroo, a little swap before we get into our next segment. So just bear with us a little bit. I'll call Dr. James Fitzgerald, who's the Director of Health Systems and Services with PAHO, to the podium. Dr. Fitzgerald.
Thank you very much, Ms. Harry. And yeah, a brief introduction. My name is James Fitzgerald. I'm the Director of the Department of Health Systems and Services at the PanAmerican Health Organization. Minister, Director, Dr. Esprit, Dr. Barbosa, colleagues, it's really representatives of the health workforce here present, and fellow PAHO colleagues. It's really a pleasure to be with you this afternoon. So we're going to shake it up now a little bit, and based on the wonderful history we've heard from Dr. Etienne, the words of context in which the Minister presented for us, and of course the detailed presentation of Dr. Esprit, what we'd like to do now is to begin to look forward, to take some of that detail that we've heard, some of the challenges noted, some of the success stories, and some of the broader context of the challenges we face within the context of NCDs now, and begin to look how we can move forward and address some issues of transformation. So I want to invite our distinguished panelists here today, Dr. Shalodin Ahmed, who's the epidemiologist from the Ministry of Health and Wellness and New Health Investment from Dominica. I'd like to invite you to the head table. Dr. Ansam Hannes, the Director of Non-Communicable Diseases and Mental Health at PAHO. And also Dr. Amalia Del Riego, who's the Unit Chief in Services and Access to the Department of Health Systems and Services at PAHO. So please. So what we're going to do now is I'm going to invite each of the panelists to contemplate and to think a little bit about what we've heard so far within the context of the challenges, the successes, and the overall global perspective of NCDs and health systems, and to reflect a little bit and present some reflections within a context of 3 to 5 minutes on some of the information, very much with the perspective of looking at the challenges and moving forward. And after that, I will begin to pose some questions to each of the panelists and potentially to the audience as well, if you have any questions for them. So with that said, I'd like to hand over to Dr. Ahmed.
Let me acknowledge the presence of Honorable Dr. Arvind McIntyre, Minister of Health, Wellness and New Health Investment, Dr. Carissa Etienne, Director General, PanAmerican Health Organization, Assistant Director, Deputy Director General, Dr. Babusa, and other PAHO health officials, Dr. Gerald, Director of Health System and Services, colleagues, health professionals, district medical officers, nurses, senior community health nurses, dentists. Good afternoon, everyone. I want to take 2 points from Dr. Kadisatian. That's very intriguing and very important that I have not seen in this primary care system. One would be the community engagement or community participation. I believe this is one of the critical point or very important point that we should include in terms of a successful primary care services. That community engagement is very important. As far as I am concerned, I am only aware of some limited engagement at the community level in terms of event-based surveillance that I'm aware of. Other point I want to take is this surveillance. Yes, is very important to me and to the Ministry of Health as well, because the evidence-based decision-making process has to come from this surveillance information or information system. We came a long way from these exercise books that our patients had been using. So at this point in time, I mean, we have a lot to talk about. I am going to go details on that in a minute. So before I continue, I just want to give you a brief in terms of where we are in terms of our NCDs surveillance. Short stats, as you have seen in slides in Dr. Laura Espiri's presentation, the number of new cases for hypertension. On average, we are seeing about 150 new cases per year for the past 10 years. And we have seen in highest number of cases in 2020, 240 cases. That is 57% increase from the national average for that year, 2020. And the yearly trend remained marginally upward. And same goes with the diabetes mellitus, that is, on average, we are seeing over 80 cases, new cases per year for the past 10 years. And in 2020, we have seen the highest number of cases, that is again 129, which is 57% increase from the national average. In terms of morbidity, we know 80% of our mortality due to NCDs. Hypertension and diabetes remain two of the top leading causes of death in 2020, and hypertension was one of the top 5 leading causes of death in 2021. With this in mind, I want to explain more about our surveillance of NCDs in Dominica. Surveillance of NCDs plays critical role in evidence-based decision-making process. Surveillance in NCDs remain at this time paper-based, yes, we're still paper-based. So we usually use a morbidity data sheet to collect those NCDs data, and it's supposed to be reporting quarterly to the national level. However, we have more challenges in that collection of NCDs data. So speaking of transformation of the primary care, we do need to give little more attention or help towards this surveillance of NCDs especially. So in terms of modernization or digitization of all our reporting system, it has to include the surveillance and reporting to the national level. At this time, I am sure the primary care overburdened in terms of using the paper-based information. I can tell you there are 220 indicators-based information that come into the health information unit, and all in paper-based. This is tremendous. So there are MCH information, there are nutritional status information, there are general morbidity information, there are mortality information, there is a quarterly monitoring reporting information. So there are so many information that all goes in a paper-based. It takes, on that perspective, it takes a long time to really collate and send out to centrally. So it will be helpful that if we can digitize this information system at the primary care level and then consequently national level, it will be helpful to receive the data on time, so we don't have to wait in order to analyze some sort of data in the following year. For example, we had to wait some data of 2021 as of last week, so it's very tedious. So we do need to pay little more effort and attention towards modernization of this reporting system from the primary care setting. So I am happy that we have come a long way from 1978 to 2021, where we are providing much more services than just taking blood pressure and checking their blood sugar and minimum care. So we look forward to, especially me, look forward to in terms of transformation of primary care, where there should be inclusion of surveillance system, ground up, from all the way from primary care to the central level. With this, I thank you and all.
Thank you very much, Dr. Hammond. Very clear messages, I think, on that and the importance of that ground-up building of the health surveillance system here to support the primary healthcare approach to NCDs. I'd like to now invite Dr. Hennis, who will reflect a little bit on what he's heard also within the broader context of PAHO regional strategies on NCDs and health systems development.
Thank you very much, Dr. James. Honourable Minister, Director Etienne, Assistant Director Dr. Barbosa, Dr. Esprit, PAHO colleagues, healthcare workers of Dominica, good afternoon all. It's really a pleasure to be here in Dominica. And we heard of the impact of NCDs in this country, accounting for 75% mortality. Probably about a third of the mortality is premature between the ages of 30 to 70. And of course, the most important thing to us all is those who actually have NCDs, who have to be managed by healthcare systems. I actually had the privilege, and I think I was paying for my sins, because over the years, Dominica is one of the 3 or so countries in the region of in the Caribbean region that I have not yet visited. I kept being delayed, there were natural disasters, things kept happening. So to pay for my sins, my director, in her wisdom, sent me to go and visit type 1 and type 3 healthcare clinics, as well as the minister, actually, and the director asked me to also do the Marriott Hospital. So I've actually now have a very clear perspective of what happens in some areas of Dominica in terms of your primary care system. And for that, I'm very grateful. So I had a far better perspective. I've heard from the nursing staff at the various clinics, and I had a very clear evolution of how the health system evolved in Dominica, mainly in terms of having care delivered at every community, as well as the challenges with transportation, which I also heard from the nurses where I went to the clinics. And I met a set of nurses who were really very professional, very engaged in patient care. I learned talking to the patients and to the nurses that the doctors, the DMOs, come to the type 1 clinics often just once a month for one clinic. I understand that the type 3 clinics, they may come twice or so a month. And when they come to visit, they're accompanied by the pharmacist. That's the access to medication and to the doctor, which I must confess I found a little bit surprising. So I saw patient notebooks, which you saw also, and I'd seen them before when I was practicing medicine some years ago in Barbados. And I recognize how important it is. But then there's the issue in terms of how does one assess how well a clinic is going if the information is in a notebook? How do you see how well your services are improving blood pressure control, diabetes control, et cetera? So I'll come back to that very shortly. So there are lessons that we would have learned from some of the natural disasters, as well as from the COVID pandemic, the disruptions in care. And when one is looking at the primary healthcare system and its ability to manage NCDs, which remain an existential threat for many Caribbean nations. And in fact, the reality is this. The Port of Spain Declaration in 2007, which took NCDs to the world stage, started in the Caribbean region. And in fact, the Honorable Prime Minister Skerritt was one of the remaining 2 or so prime ministers who was at the Port of Spain when the declaration was made to take NCDs globally. But in spite of those efforts, the premature mortality from NCDs remains highest in the Caribbean sub-region. So we still have a long way to journey to make that impact that is necessary. So what are some of the issues? What are needed for a primary care system which is fit for purpose to address NCDs in the 21st century? And you've had some really excellent inputs already. The environment in which we live, it is very critical, and Director Aide said this. You have to shape the direction shape the environment in a direction where the healthy choice becomes the easier choice. Issues of regulation. She talked about tobacco and sugar-sweetened beverages. Exactly. School environment, making the children be more physically active, getting rid of junk food, marketing of tobacco, et cetera, healthy diets. These are all things which are based on regulatory frameworks. You need laws and regulation, laws to stop the marketing to children to reduce the exposure, not just children, to older people as well. So you have to have a context which puts proper health and good health as the environment in which we all live and exist. So that is going to be very, very important. The other issue too, which one needs to speak to as well, is the whole issue of, this requires a whole of government and a whole of society input, as you've heard before, so I won't dwell too much on that. The issue of surveillance. The last data gathering, the STEP survey, took place in Dominica in 2009. This allows you to get a clear perspective on the diagnostic of the health status of the population. So unless you have the information, you don't know where you are in terms of where you need to go. So this is going to be very, very important to get up to date with your surveillance. In terms of the actual approach within the clinical setting, Dr. Esprit said it very eloquently, the need for multidisciplinary healthcare teams. So I saw really competent nurses working, but if you're going to have a healthcare team for NCDs, you're going to need to have doctors who are more available, and nurses, nurse practitioners are there as well, nutritionists, the physiotherapists, the pharmacists, access to medications are going to be a key part of this approach. And I say doctors, not there's anything wrong with nurses, but there's a whole accountability in the care delivery. The leadership of that team is going to have to reside in the doctors in terms of making decisions and treating. As Director Etienne said, if you cannot resolve a problem, they will seek help elsewhere. What I found particularly interesting is I talked to the patients in these type 1 centers. They were actually seeking help from both public as well as private sector because they were not getting what they needed at the level they thought they could. So I think that speaks to the need to provide access to care on a more sustained basis. Another issue too, if the clinic's only open from 9 to 5, how are you going to capture the men? And I saw that slide where you pointed out hypertension was not less prevalent. It may be the men not accessing services to the level that they should. So it might then speak to having access on weekends and other times, et cetera, or even after hours, to capture people who don't normally come to the clinic situation. She spoke a little bit more about the care team, then of course, the protocols. I noted from looking at their notes, et cetera, that many of the treatments were not necessarily in line. And this is not only unique to this situation, this is quite universal. So one has to follow standardized best practice protocols based on evidence, and they exist, and they work. So it requires a rethinking of delivery of care and then the accountability of care. And if data are actually computerized and available for comparison, you can then see how well the health system is functioning, not just in terms, as Dr. Esprit said, in terms of numbers of visits, but in terms of improvement in blood pressure control, blood sugar control. And this is like the basis that underpins the whole steps, the whole HEARTS initiative. You can show improvements, and over time, you can actually, by improving blood pressure control, reduce mortality. And that is where you have to think about what is our healthcare system delivering for NCDs. So then moving then to information which is digitized and available. Monitoring and accountability. in addition to doctors taking leadership and delivering quality care that is measurable, there's also the issue of continuing medical education and training. We talked about also the possibility of having access between specialists and engage at the primary healthcare level, which actually raises the standard and improves the quality of care delivered at the primary healthcare level. These are issues that we've seen work very, very successfully in other settings. So it raises everything and actually provides better care for the patients. So in terms of going forward, one has to consider how to strengthen primary care, how to optimize treatment, and how to rationalize treatment. So Dr. Etienne gave you a very clear perspective of how things evolved and how they developed. And also we now need to consider what is a primary health care system that is optimized and is transformed to be fit for purpose in delivering care in the 21st century. And that really is the big question. We have many different ideas, but I think this is going to be a priority if we're going to have an effective approach to managing NCDs in the 21st century. Thank you.
So thank you very much, Dr. Hennis. So what we're beginning to hear is many issues coming up: protocols, standardization, care teams, really strengthening capacities, looking at health surveillance. So I'd like to ask Dr. Del Riego now, Amalia, can we bring this together now within the health systems perspective? How do we ground this within the organization of health systems to really begin to transform our vision for the future and to be able to tackle NCDs moving forward?
Thank you, James. And protocol, I think, was established. So good afternoon. I would like to, it's 5 minutes, right? So the first thing I would like to say that if we are looking at transformation from the health systems perspective, I like to start with the word passion. I think you need to really have passion, a shared vision, commitment, and a clear roadmap. So let's say that from the health systems perspective, look into the future, that will be a practical, feasible intervention to do. And we see in different situations that when you don't have that shared vision, and even if it's in a document that all stakeholders can identify with and follow and contribute to, it's difficult sometimes to keep the process going, because this is not going to happen overnight. It's not going to be in 1 day or two. It really requires a long trajectory. Aligned with that is what mechanism can be put in place, and I think it was mentioned in both Dr. Etienne's intervention and Dr. Sprit, the fact that you have to define that roadmap, define that clear strategy, but also have mechanisms for accountability, monitoring. It does not need to be complicated, but that needs to be really set up. So for me, that is one element that I wanted to highlight. The second element is, I think a lot of the things that we heard in the different presentations are related to a big component of our regional approach and the call to action for primary health care and for universal health that we call, the director called the Compact 30-30-30, which is access. 30% reduction of barriers to access. And why I'm saying access is because when we look at not only the availability of services, but also what are the potential barriers that we have for the people to actually access health and health services. We want to talk always about health and health services because as it was very well said, we need to think about the social determinants of health. And so access also thinking about how do we configure our primary care facilities and teams in a way that the teams are prepared and equipped for the provision of services, but also for all of what it was mentioned, intersectoral action, engagement of the community, the issue of quality. If I go to the health center and I don't have the basic care, and the care is not a quality care, then I'm having a barrier to accessing quality care services. So that component of how do you really think the 42 health facilities type 1, the facilities type 3, linked to teams that are motivated, engaged, and that will be to me the other element. We need champions. We need the health providers to be totally engaged. We need the community. We need the people to be totally engaged. We need them to feel part of the process. I remember 4 years ago with the renewal of the 40 years of Alma Ata, that was like, no, we need a big movement in the region for primary health care. And that only is possible engaging people and engaging the health providers. So part of the change will be possible with high motivated health providers engaging in a shared vision and a structured roadmap to move forward. And last but not least, financial resources. I don't know if it's, what I heard is correct, but you will correct me if I'm wrong, but I heard that 7.9% of the budget is allocated to primary health care. So our call for action is that we are saying we need at least 30% of the budget allocated to primary health care. And we need not only 30% allocated to primary care, but we need that those resources are utilized in an efficient manner so that the investment will be targeting the areas that need to be improved, but also that we can rationalize the resources that are available. And I said last but not least, but this is the last one. So the coordination of care, which I think is very important to ensure the continuity of care, because when we think about primary care and primary health care, we know that that person will need some support for other services, and those services are probably at the hospital. What we want at the end of the day is to prevent that people go to the hospital, so that they just go to the hospital for what is really needed. But precisely because of that, we need coordination of care. And I see a great opportunity here with the big project in terms of digitalization of digital transformation, because that technology can facilitate, is another practical way of facilitating the coordination of care between different facilities. And I think I will end up there. Thank you.
Do we have, so may I ask, do we have time for a couple of quick questions? I think so. Let me see if there's any questions from the audience. I have a couple of questions from what I've heard, but maybe let me see if there's any questions coming from our participants today. Anybody want to pose a question to the panel? If not, I'd like to pose a question to each of you. And the question is around the word integration. We've heard from our presenters today that this cannot happen, this transformation cannot happen without an all hands on deck approach. Leadership from the health sector, participation of other sectors, engagement of the workforce, creation of multidisciplinary teams. Can I ask each of you to talk a little bit about integration, how we integrate our efforts? Perhaps Dr. Ahmed on the integration of surveillance with the digital transformation process that's ongoing in Dominica. Perhaps Ansem really focusing and honing in on the overall strategies to control and manage NCDs, including risk factors with health systems. And then Amalia, really coming back to that issue of integration from all levels of government, this whole of society approach that's required to really move forward the transformation agenda in Dominica. And I'll give you 2 minutes each.
Okay, integration part, if I may speak on that, would be we do have national public health surveillance and, we do have the National Public Health Surveillance and Response Team, which is very integrated. That includes most of the core managers that we meet. So this is at the national level, that is basically. So that integration will speak to any matters, not only just NCDs or primary health cares. All health matters are discussed, are mitigated, or trying to resolve or get solution to it. So in that aspect, yes, we do have some limited integration process already in place. However, the community engagement or community involvement, that needs to be much more pronounced. We are not seeing that level of integration as yet. So it will be very helpful how best we can really integrate those community leaders or those who actually, this COVID actually helped us to think broader than outside of health sectors. So we can involve other key players from the community level in order to solve some of these problems. I was involved in backyard gardening in one of those communities, and we were able to try to get bottom off in terms of iron deficiency anemia in one of those communities. And so that program was speaks to people who are in the community. So the community, those who are in the community leaders, the health professionals of the same community. So that approach to address a community level problem can also help long way. So it should not be limited to only among the health professionals to solve or bring solution about, but if we can engage the community, that will be another key stakeholders that needs to be integrated into our health related issues or problems.
Right, okay, so thank you very much for that question, James. And so let me share some thoughts about the whole idea of integration. So I'm going to start in terms of policies beyond health. Set the environment that is in favor of the well-being of people of NCDs. Okay, so again, the issue of tackling tobacco, physical inactivity, that whole external context, the whole of society, the intersectoral approach. So in other words, policy coherent across government. And what we see often, not necessarily here, is that you, for example, have the Ministry of Finance given the okay to tobacco sales. And why is that? Because the taxes come in and they go to the Treasury, so it helps the bottom line. But while you're making money off taxes, people who are smoking them in the community are actually getting the complications of cigarette use. So in the short term, you get a bump in your intake in the Treasury, but longer term, you create a cohort of people who are going to cost you dearly down the road. So there must be policy coherence across the government, which is not just simply a whole of government approach, but a policy coherence in doing the right thing for your your citizens. So I'm going to use the whole idea, the whole concept of integrating the way that governments behave intersectorally. Now, let's look at the whole idea of integration of care. I think one very good example is the whole idea of diabetes. And that creates an opportunity for a multidisciplinary approach. So it's all the issues, for example, nutrition, foot care, eye care. I was very pleased to hear about the diabetic clinic in Dominica, access to medications, insulin, etc. So if you're going to give an appropriate approach to people with diabetes, you have to have all the resources available to them. And what is very, very important is the management of hypertension. Managing hypertension and controlling hypertension while in diabetes is probably one of the most important issues to reduce renal kidney disease and kidney failure. So I think the whole approach at that stage in terms of care is critical, nutrition, all the other elements. And it's going to be not just something within the context of giving care, but also in terms of support to those providing care, the caregivers, the family, the bigger, broader context of the community. And I met a very interesting patient who was probably in her 70s, and she was on insulin. She said she had diabetes since age 30. She's probably about her 70s. But she was the one who was a sergeant major. I had a team, and we exercised. We get together in the mornings, and they expected the weight to come off, and it didn't, so they dropped out after a year. But I'm still going strong. You need that kind of motivating sergeant major in the community, people around them, to inspire them. And so you have to find a way to integrate healthier lifestyles at the community level, led by patients or those supporters, to make that difference. Because it's a long haul, it's a whole lifestyle change. So that also has to be part of it. So civil society also has to play a role as part of the integration of approaches to NCDs. And they can be very, very powerful advocates. And I think governments must engage civil society in a meaningful way. I'll quickly use the example of front of package labeling in the Caribbean. And Minister, I'm sure you've heard about some issues that are ongoing with the front of package labeling. And all the issues, the fact that after decisions were made, they were then reversed, et cetera, et cetera. And I've been working very, very assiduously on those issues in the last 4 to 5 days as well on the site. And I'm sure it will come to your attention, probably meeting at the end of this week. But the bottom line is now, you need to give people access to information which is simple, easily understood. And the front of package labeling tells you which products are harmful to your health among processed and ultra-processed products. And the cross-SKU process has been able to say the label supported by PAHO actually communicates very effectively and very simply to the consumer to make the right decision about what to buy. So again, in these issues, trying to have an integrated approach, a whole of environmental approach to what people should do for their health and well-being remains very, very important. And this is just another limb of it. So there are many, many elements of it. I hope I've touched on a few of them, but you need to empower people with the best information to make the healthier choice in their interest. And this is a responsibility of not just governments, but of us all. Thank you.
So, 4 elements from the health system's, perspective for integration. I think from the policy level, I will reinforce the idea of a national strategic plan that can be built upon with intersectorial, interdepartmental engagement, and even community engagement in the mechanism to implement and follow up that. That is a level of integration at the policy level. Related to that, integration also needs to be expressed in financing and budgeting, because if our financing is fragmented, segmented, that is going to make very difficult to actually make integration a reality. So the financing and budgeting process is also another element that needs to be taken into consideration for to promote integration. And specifically, the definition of the package of services that will be guaranteed, or the government is committed to guarantee for the population, aligned with those resources. Why? Because it's in defining that the process, the decision making can really be embedded to ensure that the services are comprehensive, of quality, at least in the definition, and then you can facilitate investment and implementation. That guides a lot the investment. At the delivery services, of course, the integration of the network, we spoke about that, and the coordination between primary care facilities and teams with the hospitals, and information systems. A unique health record shared among all the health providers is a very practical way to facilitate integration.
Excellent. So thank you very much. We could go on for hours, but unfortunately we don't have hours. It's been a really fascinating discussion. I think we should give our panelists a warm round of applause. And I wanted to really thank all of you here also for being active participants in this process, and listening and reflecting on what we've heard within the context of your reality. So thank you very much. Ms. Herring?
Thank you so very much. Let me thank Dr. James Fitzgerald, so very capably moderating our panel discussion this afternoon, and thanks to all of our panelists. I'd like to welcome to the podium to offer a summary of the outcomes, the Assistant Director from PAHO, Dr. Jabez Barbosa.
Thank you. Good afternoon. Honorable Irving McIntyre, Minister of Health, Wellness and New Health Investment, Dr. Laura Esprit, Director of Primary Health Care Services, the Minister of Health, the executives of the Ministry of Health, the Dominica Hospital Authority, healthcare workers and providers, our director, Dr. Carissa Etienne, my colleagues from PAHO. Allow me to first congratulate all the presenters for providing us with a comprehensive overview of key policies and interventions to strengthen primary health care, to address the burden of non-communicable diseases in the interest of the health of the people of the Commonwealth of Dominica. I want to highlight 5 critical and strategic issues noted by the presenters today that form the basis for a roadmap to transform primary health care in the short, medium, and long term in Dominica. Firstly, addressing non-communicable diseases and protecting health gains in other areas will require strong primary care and integration, coordination of care and services. The improvement of health promotion and prevention, and capacities for early diagnosis, management, and care of prevalent conditions. I was thinking about that figure that was presented by Dr. Esprit about how many men we have in Dominica that have hypertension, that have not been detected yet, and they will only be detected when they have a stroke. So if you don't have a proper strategy to reach out them, we are creating a very important group of people that will suffer a more severe problem in the near future. So I think that this is one good example from this panel that we had today. In other words, it means that we must strengthen the primary health care approach with a people and community-centered model of care to ensure equitable access to comprehensive quality health care services. That, I believe, was crystal clear in our discussion today. Secondly, there is an urgent need to improve capacities at the primary care level to improve comprehensive management of non-communicable diseases, and that means having standardized guidelines, protocols, training of primary care providers to deliver services for the detection, diagnosis, treatment, and care of cardiovascular disease, diabetes, chronic respiratory diseases and cancer, community outreach and education, counseling for health, lifestyles and self-care, self-management, team approach, communication, and referral system between primary care and this specialized care. Third, we have heard of the need to transform primary care services. The current Type 3 health centers need strengthening to expand capacity and provide a wider range of services in support of satellite Type 1 community health and wellness centers. The health workforce will need to adapt to the needs of the population, including general practitioners. We have heard of the need of emergency care 24/7 at selected sites, medical specialist consultations, extended pharmacy services, and full laboratory capacity for a range of predefined exams. We also have identified the need for the introduction of health technology to increase capacity for ambulatory care health and wellness education, intersectoral action and community participation programs, outreach mobile programs for home care, health promotion and prevention activities, among other services. Coordination of care between primary care services and hospital care is essential. Fourth, we must be guided by information, evidence, and quality in all aspects of our work. From the collection and analysis of health information to the development of clinical pathways and standards of care. Our director, Dr. Carissa Etienne, provides very interesting example of how we collected data at that time, how we have maps that were not digital maps, but it worked because it provided all the elements to perform analysis. So the technology that we have today will be very useful because we will have more time to provide better analysis. So if we are not using the technology that are available to perform the analysis, to identify barriers, to identify vulnerable groups, I think that we are presenting in a more fancy way, but it's not really providing the better use that we can do to this. And as our director mentioned, there is a very important interest of the government of Dominica to move in this digital transformation, that the health will be a very important beneficial of this effort of the government. So I do believe that in a couple of months or years, we will have all the information related to a patient will be available at the primary healthcare level, the hospital, to provide better analysis, to identify people that are being left behind, people that we need to develop and to adapt the strategy to reach them out. Fourth, I said that we must be guided by information, that from the collection and analysis of health information to the development of clinical pathway standards of care, from the development and maintenance of digital health records to performance standards and data for health services provision. The network of health services across the island must be subject to an ongoing review and digital transformation. Norms and standards from the national formulary to the more complex definition of a package of services will require renewal and investment to ensure that we are applying the best evidence in the provision of care and in a manner that optimizes quality of service. And finally, we need to ensure the necessary resources to bring about these changes. We must address healthy workforce challenges to ensure that we attract, capture, and retain the most well-qualified Dominicans and international workforce to work in primary care and public health. This will mean ensuring the necessary working conditions and incentives to ensure excellence in health service provision, while updating regulations in healthcare practices to optimize service provision within the public sector. Workforce planning, policies and regulations based on a clear definition of service, a service offer, and the standards of practice will be required. All this will not be possible without financing. The transformation of primary care services will require significant resourcing. Investing in the health of people means investing in facilities, services, and the necessary inputs, including health information systems, medicines and health technologies, and of course, the workforce. Identifying efficiencies in the allocation and use of existing financial resources will be important. However, some dialogue will be required to increase public financing in health without subjecting the population to out-of-pocket payments at the point of service. PAHO is committed to support Dominica in executing a detailed analysis of fiscal space for health, identifying opportunities to define the best path forward for health finance in the future. It's a challenge for the Ministry of Health and the Ministry of Finance to identify resources for the health system as a whole. Finally, and the most important determinant of success is the strengthening of the Ministry of Health capacities for governance, stewardship, and public health. The transformation of the health system in Dominica will require updating its organizational structure and improvement of capacities of the Ministry of Health to strengthen its stewardship and leadership functions and to meet new functions and expanded responsibility. This includes those related to epidemiological assessment and surveillance, non-communicable disease care and management, and information systems for health, international health regulation and disaster preparedness and response, human resources planning and development, strengthen the essential public health functions, and most importantly, the improvement of the management of primary health care services, coordination with the Dominica Hospital Authority, and building the trust and participation of people, communities, and families across the island in a well-organized, structured, and financed health system based on primary health care. We at PAHO are committed to support the Ministry of Health in the review and update of the National Health Strategic Plan and the development of a roadmap for the development of the health system that addresses the increasing burden of disease and risk factors from NCDs in Dominica. We look forward to working closely with you in this task and improve the health and well-being of all Dominicans well in the future. Thank you very much.
Thank you so much to the Assistant Director of PAHO, Dr. Jabez Barbosa. And that takes us to the end of our program for this afternoon. On behalf of the Permanent Secretary within the Ministry of Health, Wellness, and New Health Investment, of course, the Honorable Minister of Health as well, I'd like to thank all of you for joining us for this symposium. There are quite a few takeaways from this symposium. One of them that we hear mentioned a lot is collaboration. And it's not just collaboration across sectors, but even within our own ministry, where no matter at what level you may be within the ministry, it's essential that we all work together, work comprehensively to ensure the best care for, the people that we love, our country. We are focusing so much on health and wellness. And the wellness part means that we have to work together to ensure that they are well. If we don't do that, we cannot give them the best service that they deserve. So collaboration. Adaptation is also something that we hear a lot about because the old way might be good, but sometimes new ideas may be better for the wellness of our people. And of course, integration, health and wellness. Not just care, but prevention as well. So we have to find the best ways to ensure that these things coincide, work hand in hand for the health of our people. Let me take this opportunity to thank His Excellency the President for hosting us so graciously all day. We've been in his house all day. So thank you so much to the President. Thank you so much to my media colleagues for their patience and tolerance of me and the needs of this symposium. So thank you for accommodating us so graciously. I'd like to thank all our PAHO delegates who remained with us throughout today and who engaged us and all the panelists for your efforts today, all the presenters for your efforts as well. The staff of the Ministry of Health, thank you so much for coming through and for participating. So that's all for us today. Thank you again, everyone, and we wish you a pleasant evening. Get home safely, and I believe there's a little refreshment afterwards, so feel free to mingle a little bit and enjoy some refreshments courtesy of PAHO and the Ministry of Health. So thank you, everyone. Have a pleasant evening.